Thank you. Thank you for coming today. Wonderful, wonderful group of people. I've been able to meet a bunch of you, and your stories are amazing. So we're going to have Dr. Stobbe come and talk in a minute. Then that's going to be followed with a panel, and Dr. Stobbe is going to be the moderator for that panel. Thank you, panel. I want to recognize a group of students who were very active in helping put this together. And I don't know, were people on the advisory group, the student advisory groups for the initiative? Ellen, I see you back there. Audrey, I see you back there. Can you raise your hands so people can see you? Anybody else? Okay. Yeah, they helped put this together. Carol Brown, who you just met, made this happen, literally. So when you see her, thank her for all her very hard work. And there's lots of volunteers around. They're dedicating their day to being here to lead you, if you answer questions if you have them, right? So it's my pleasure to introduce our first speaker today, Dr. Gary Stobbe. Dr. Stobbe is a board-certified neurologist. He earned his medical degree at Albany School of Medicine in 1989 and completed his residency in neurology at UCLA in 1993. I first met Gary at the Autism Spectrum and Treatment Center that was also known as A-STAR. How many people remember A-STAR? Yeah, got fans out there. It was an innovative, nonprofit clinic that served individuals across the spectrum and their families. This really was like the first place in Seattle that really worked to meet the needs of individuals on the spectrum. It was an exciting place. He was the medical director there from 2003 to 2009. And a number of our SPU doctoral students had the privilege of working at A-STAR during that time, and I frequently heard wonderful stories about Gary and his supervision and training that he offered. He joined the faculty at the University of Washington in 2008 and is currently the clinical assistant professor in the departments of psychiatry and neurology. Dr. Stobbe also serves as the director of the Adult Transition program at Children's Autism Center. So join me in welcoming our speaker today, Dr. Gary Stobbe.
Hello, everybody. Can you hear me in the back? Okay, great. Well, thanks for coming this morning. It's a beautiful day. Some of you guys, I recognize a lot of faces out there. Gluttons for punishment, just continue to come, and it's great, and we need to continue to build, in this community, and we're going to talk about that today. We'll get our slides going. So I've given this talk a number of times. I try to keep the slides a little bit fresh with new information, and this is an area that I've really enjoyed working in my career. I never predicted that this is where I would be standing when I left, certainly medical school. I often say I'm the old guard, the old generation. When I was in public school, children with autism didn't go to school with me. I didn't meet somebody with autism until I was in my residency at UCLA. So we've come a long way with inclusion, and I feel like we've got about a similar amount to go forward. I feel like maybe we're halfway there. And a lot of you in the room who are here who experience autism firsthand, either yourself or as a family member, recognize the issues around transitioning to adulthood as a big concern. It's one of the questions that I get when I'm involved in the early stages of diagnosis. One of the questions we get is, what's the cause of this? And one of the questions that we get is, what's the future look like? What can we expect going forward? So we're going to focus on that second question. I am going to get us grounded a little bit on some of the basics as we go. So no conflicts of interest today. We're going to look at a couple things. We're going to look at what we think about as trajectory in the autism spectrum, the trajectory of outcomes, so to speak. We're going to look at factors that we understand influence those trajectories. And then what can we do to both define success and help meet that success in adulthood? So let's go a little bit of background. The autism spectrum is defined as a complex of features that are behaviors that stem from what we think of as neurodevelopment, so development of the brain. And it has evolved over the years in its definition, and it really has expanded in the sense that we include more people in this definition than we used to in years past. And it is really two core elements that define the autism spectrum. On one side is an area of lower functioning or deficiencies in social communication compared to the average person the same age. So difficulties in verbal or nonverbal communication, eye contact, things such as this. Sometimes a lack of desire in social communication, but sometimes more just a lack of social skills in this area. On the other side is this strong, hyper-focused areas of interest or repetitive behaviors. And these features need to stem from childhood, from early development. We used to say it had to be apparent before age 3, but we became very aware. A lot of individuals really, you didn't notice the differences and the difficulties until they were immersed in the school setting, around their peers. So that's you can really. We will have some individuals that don't get diagnosed until age 7, 8, and as you'll see by one of my slides, not until adulthood do they get diagnosed. There's no subcategories like we used to define. We had these terms Asperger's and PDD-NOS, which stands for pervasive developmental disorder not otherwise specified. We've kind of lumped all of that, and we call all of that autism spectrum. We still use Asperger's. I think Asperger's still has meaning and relevance. It implies a group of individuals that have, from childhood, normal speaking ability and normal IQ, and often go on a higher trajectory of outcome. So some people, when they're some that are self-identifying might resonate more when they Google Asperger's as opposed to Googling autism. So we still do use that term. The definition of autism spectrum disorder is not defined by a knowledge of the cause. Okay, so when that first question comes to us about what's the cause of this, the answer is a lot of hand waving. The real answer is we don't know. Although there are some cases, and we're getting better at this, at identifying underlying biological-based syndromes in which autism is a symptom or a feature of the syndrome. So, for example, individuals with Down syndrome, some of those individuals also meet criteria for having autism as part of their Down syndrome. So we use the term syndromic autism for individuals where we can identify the underlying biological cause. Okay? Most individuals, we don't know the cause, and that's where we see the very strong male to female differences, so more males than females. And those individuals often have fewer other conditions, except when you start to talk about other mental health conditions. So depression and anxiety is common in that group as well as in the so-called syndromic group. Okay? So there's a number of reasons that we've seen an increase in the prevalence of autism spectrum disorders over the years. So back in the 1970s and 1980s, we were talking about 1 in 10,000, 1 in 1,000, and now we're at 1 in 68, some numbers even higher than that. The question is, does that represent an epidemic? And the answer is, we don't know. although probably not. So the difference is that all of these studies are what are called prevalence studies as opposed to incidence studies, which means that they're influenced by things such as what's the age that they're diagnosed, what's the recognition and awareness factors, how do we define autism spectrum, and all of those features. The age has come down, we've expanded the diagnostic criteria, there's more awareness, all of those factors have influence. There was a study done out of the UK a number of years ago, a very high quality study that went door to door in a neighborhood of adults and did screening and then diagnostic testing, and the rate was about 1 in 100 in that neighborhood of adults. If it was an epidemic, you wouldn't have expected that high number, okay? So, why does that all matter? It all matters because there's a lot of people that have autism. The number is very large. How many in Washington State? We really don't know. Nobody has good, accurate numbers. You know, if we extrapolate, the number's large, over 100,000. Maybe not enough to swing a caucus vote, but still a large number. You know, so much that, you know, we get, you know, what do we call this? Is it a natural, regular state? Is it just an alternative state of the brain? And there's a lot of fun debate on that topic. Clearly, some individuals that meet criteria for autism have functioning in the brain that is causing a lot of problems with their success. And so, however we call it or name it, we want to, as parents and as a community, we want to support individuals just like we support everybody else. We want everybody to have successful lives and outcomes. And so that's our focus. So we've learned a little bit more about our population here in Washington State. We opened a clinic at University of Washington in 2012. This is a little bit of outdated slide. We see about 500 new unique patients per year in that clinic. We did a study in the first 2 years. We sampled almost 400 charts. We did a retrospective chart review looking at kind of the demographics of our patients. And I think there's a couple points here worth highlighting. So our patients were pretty representative of what we know with autism as a whole. Looking at the male number, about 2/3 are male. You see only about 16% of the individuals living independently. You see about 2/3 of the patients are on at least one medication for behavior. So either anxiety or antidepressants or ADHD medications or sometimes even stronger behavioral medications. And so those numbers are representative of other populations that have been studied. So we feel like we have a fairly good representation of the population. What we weren't expecting in our clinic was that 1/4 of our new patients were undiagnosed and were seeking a diagnosis. So a large number that some of them would go on and receive a diagnosis, others didn't. So, and we broke out those groups. If we looked at patients that already had an autism diagnosis versus those that were seeking a diagnosis. So now we've actually take out just looking at autism, and we see our living independently goes down to 8% in that group. And we're looking at the average age, though, is 22. And a really concerning number, and we'll focus on this going forward, is employment rate at 13%, so very low. And again, we see this large number of behavioral medications, about 3/4. This is probably some sampling bias here. We're a medical clinic, so you can imagine that we're drawing more patients that are on medications or need medications. So there is probably some bias there. So what we've seen in this clinic and what I've seen over my career, I've had a luxurious career from the standpoint that I've been able to work with kids aging into adulthood. I still see my first autism patient that I met in my private practice up in the early 1990s. He's in his mid-20s now. And so I get to follow along, which is fantastic. It's been super helpful for me, for my understanding of this concept of trajectory. And one of the things that I've been impressed by is progress that continues in the 20s and 30s in this group. So it's almost like, so if you look at developmental progression, and if we're really focused on the concept of social communication development, what we see in the typically developing human is you see an exponential rise in social communication development through childhood, through the elementary, middle, and high school years. And then it plateaus, and thankfully, our 18-year-olds continue to mature with their social communication development into adulthood. But it is flatter than when during their earlier years. Whereas an individual on the autism spectrum will make progress at a slower rate. So the concerning thing in school years, of course, is what you're seeing is despite progress in the individual with autism, they're falling further behind their peers for a period of time, okay, which is very challenging in the school system. But later on, they catch up. The concern here, though, is, and what we're seeing sometimes at the clinic, is right around this time, what happens? Age 20 to 25. Services go away. There's a big cliff in services. School goes away. Those of you that are parents out there are starting to feel a little burned out, maybe. The relationship is getting strained. Your child is a young adult, is kind of tired of you telling them what to do. So a lot of events occur around this time and place our young adults at a higher risk for not reaching their potential and not reaching their goals. So let's kind of dive a little bit deeper into then some of the features and factors that seem to impact trajectory. You guys know Will Kerner? Who knows Will Kerner? You should go to his website, Will's Paper Cutouts, to see his art. Will's about 20, 21 now, minimally verbal. He'll take these paper cutouts and organize them on a table in this beautiful artistic form. He'll then mess them up, but before he messes them up, his grandmother comes and takes a picture of it, and then she recreates it. One of his pieces sold for upwards of $15,000 to $20,000 recently, so his art has become very popular. And I tell this story, we'll come back when we talk about employment, and we talk about creative ideas to have successful employment. So I showed that one schematic graph as if everybody follows that same trajectory, and obviously that's not true, right? So I like to think about it as really kind of three trajectory groups. So there's one group that's phrase has been coined optimal outcome group. So this is a group that is diagnosed with autism spectrum disorder at age 3 to 4, and you follow them out to age 18, and if you put your blinders on, disregard their early development, and you look at them just at age 18, they no longer meet criteria for autism, okay? That's a good number, 1 out of 5. I like that number. What happened? Did we misdiagnose them? Did they get cured? Did their developmental trajectory just innately was going to go in that direction? Did something we do help that trajectory? Those things are uncertain. Maybe a mix of all of those. Unfortunately, there's a number that's of a similar size that has what I think all of us would consider a poor outcome from the standpoint of independent living and being able to be successful in the community. These are individuals that require really 24/7 support for living. The majority of individuals make progress and continue to make progress. Okay, and that's a larger group. So what have we learned about factors that influence this? I kind of break this down into what I call intrinsic and extrinsic factors. So factors that are related to the individual themselves, and then factors that are related to their outside world. So if we look at some of the intrinsic factors, one of the biggest factors is their cognitive ability. Individuals that have intellectual disability in addition to autism, that's a predictor of a worse future into adulthood. The severity of their core autistic features, and this is where it breaks down into the old categorization on DSM-4, where you actually break out communication from social interaction. Because you can have an individual that talks perfectly well, but has no interest in social interaction. You can have a person that's nonverbal, but is very social. You can have a person that's verbal and interested in social interaction, but all they talk about is Star Wars 24 hours a day. So all three of the features from that standpoint are kind of independent variables. Specific behaviors, spitting, hitting, if that becomes a behavior that gets entrenched in the person's life, that can be an independent variable. I highlight mental health, and we'll highlight that on a slide going forward, because that's something that we really focus on in our clinic and something that we feel like we can have a strong impact upon. And then other medical conditions, epilepsy and sleep disorders, both have been reported at a much higher incidence in individuals that have autism. And then these are unfortunately kind of the ones that we feel bad about. The ones in which there's a disparity on access to services that's socioeconomically based, that's based on a regional basis, if you live in rural areas. Access to early intervention has been well documented now about the progress that can be made with early intervention. And then I want to highlight this concept of case management, and because then I think that highlights with really what we can be doing as our youth age into adulthood. So this was a study we published last year. Emily Myers, who's one of our developmental pediatricians on faculty at UW and Children's, looked at this large database. It's a national database, and pulled out was looking at developmental disabilities as a whole, and she pulled out autism specifically from this database. It was a group of people nationally that had been followed since early teen years into their early adult years, and they would get a phone. They would do a phone questionnaire one-on-one with a person, would interview them on the phone over waves. So let's say age 13, age 16, age 19, and age 22. Okay, and ask them a bunch of questions about health and school and their community. And we looked at two specific things. We looked at community participation and social participation. So community participation was defined by questions, did you participate in Special Olympics, or were you a member of a club, or are you in a band, or things like that are kind of community based. And then social participation, did you have a get together with a friend? Do you speak to friends on the phone? Things like that. So I want to highlight a couple points of what we found. So if you look at these bar graphs over on the left, this is during early teen years, and then this is during adulthood. And this is a yes-no answer to the question. So if you look at the purple one, this is the question of if you answered yes to any participation outside of school in the prior 12 months. So in between 60 to 70% of people said yes, they did. And look how that went down into adulthood. So community participation is decreasing. Now that should not be that direction when we look at this other trajectory of progress. So it's not the individuals that are failing, it's us. We're failing as a community in supporting them, okay? Now, social interaction actually improves and does a little bit better, okay? So that is nice to see. And again, I think it supports this concept. It's not them that's failing, it's us. The second thing, though, to highlight is this is people that just said they did, if you said no, that means you had 0 participating events for 12 months. I mean, we're talking about adults. That means over 50% had 0. That's just a concerning number. And then the third thing to highlight is one of the factors that influenced these numbers was whether or not the person, and it was usually the parent, answered a question of, does your child have a case manager? And if they answered yes, these numbers look better. Okay? Now, it didn't ask, what's a case manager? What are you in your mind defining as a case manager? I would argue, of the families that I see, most often the case manager is the parent. And again, this is a concern because, as we said, the parents are burning out. Okay? And the parents are being asked to do things that, that didn't come with a playbook. There wasn't an instruction kit manual on how to do this. So it's very challenging to be a case manager as a parent. There are some advantages. You know your child, your young adult child better than anybody else. But there are some aspects of the work that you do as a case manager that you're not designed to do. And you have a lack of information and access to information to do your job as a case manager. So one of the questions that we have is how do we support that? And how, as a community, as a provider myself, how do I support and enhance that? How am I doing on time? Any idea? I got about 20 minutes now? Perfect, thanks. Okay. Josh Perkins is a young adult, graduated from Seattle Art Institute. He draws these by hand, pretty nice work. All right, so let's think about how do we enhance and how do we improve all of these numbers. Well, first, I guess the question asked is, what is success? And we redefine success for our children and our young adults often. And individuals that are on the autism spectrum, often we redefine success. Who has in the room has a child under the age of 3? Anybody? Well, I have a grandson who's 14 months old now, and you kind of go into being a parent with a view of what you think should happen for your child. And when the autism diagnosis comes along, that's kind of wiped out. You have to replace that, and with that comes a lot of fear because not knowing the future kind of tends to generate fear. So one of the things we have to do is we have to recreate what is success, what's our goal. We have to remember that the primary goal is the same as a parent and as an individual, is to be successful, is to be happy and healthy. It's really the same definition, but the route may be different. Okay, and you have to not be comparing often to other people, which we have a tendency to do. So if we looked at this question with a number of parents that were participating in a class we call Next Steps at Seattle Children's Autism Center. These are typically parents that their child is age 15 to 18, although sometimes older. And we ask the question to the parents, what are your long-term goals for your son and daughter? And we see them kind of fall into 4 different categories. So we see this category of community access. So living in a group home with a caretaker to oversee him and ensure he is okay. Living independently, finding permanent housing. So aspects of living in the community. We saw some questions related to health and wellness. Safe, well cared for, eating healthy food. We see friendship and social interaction as a goal, more face-to-face, in-person and making friends, relationships with a female partner. And And we see education and employment. We see having a job that pays well enough to live independently and have health care, a meaningful job, and continued opportunities for learning. So let's kind of look at some of the barriers to those in those areas, and then we can think about how we might break down those barriers. So one of the barriers is again, gets back to this kind of case management and the providers. So if you look at physicians, we're not doing a good job of exposing physicians to this large population in physician training. So in their residency years, as a result, there's a lack of confidence amongst providers in working with this population, and there's a lack of confidence in the families in their providers. So it's a bi-directional lack of confidence that occurs, and that's a problem. We don't have good tools to help providers in the transition process. So these pediatric providers and helping them transition these youth into adulthood, we're lacking well-defined evidence-based tools. We've talked about the anxiety and the planning. We talked about the burnout, the financial barriers you can imagine, and a lot of individuals in their on the autism spectrum, when they're in their early 20s as they age into adulthood, they're not ready to take the baton completely by themselves. There's a big race disparity with regards to transition planning. I would say just access to services across the board. Again, this gets into also additional rural-based and socioeconomic-based, as we talked about. As a result, for this population, if you compare it, and this is a number that, again, if you look at a number of different factors, and we'll see this again in employment, the autism spectrum population seems to have a disadvantage over other developmental disabilities. Their numbers always look worse compared to other developmental disabilities. And maybe that's some of the inherent social communication deficit that occurs, the repetitive behaviors, some aspects intrinsic to the autism may make them a more disadvantaged than other individuals that have other developmental disabilities. So as I highlighted in that other slide, this is a big area of opportunity. Currently it's a big problem, but with problems hopefully come solutions. And these are just some highlighted statistics showing what a big problem we have with regards to superimposed co-occurring mental health conditions. Okay, and this does not even include maybe the biggest one that we see for more severely impacted individuals, in which they have what we call disruptive behavior that can be self-injury or aggression towards others. That people that are outside the autism field think that that's just comes with the territory with autism, and it doesn't have to. I mean, that's a concern. It's not part of the definition of autism. If you look at the DSM-5, being aggressive towards others is not core to the condition. Okay, so again, we have a lot of work to try to change that perception. That's amongst my peers and colleagues in other fields. Okay. So this is kind of highlighting school and employment, and again highlighting that what we saw in our clinic again is seen nationally with regards to employment rates. And this is regardless of whether or not you have co-occurring intellectual disabilities. So the so-called high-functioning group also, with similar low employment rates. Some of this is probably related to, again, the individual, but some of it is related to also our services that are available. There's a lack of specific training for job coaches in this area. Look at this interesting statistic. Decline in employment status over time, more for women, 15 times greater for women. We think that some of that may be, again, the social challenges that women face and maybe the higher expectations for their social abilities. And this is, again, just kind of highlighting the same thing of lack of services. And then in the last area of health, some statistics that really highlight that we are failing in this area as well. We don't have a lot of data on this currently. This comes from our kind of largest prospective cohort that's being followed over time out of the Weissman Center at University of Wisconsin. They've been looking at premature deaths, and those have included higher numbers of cardiovascular deaths and deaths related to stage 3 and 4 cancers. And the thinking there is that there's a lack of health screening that's going on. So if you're an individual that is a low communicator, you're not necessarily able to recognize or communicate when you're having symptoms early on. And a lot of our primary care providers are not insisting on, and our families are not insisting on those individuals having annual physical exams and getting the appropriate preventive health care that everybody is entitled to. So an example, we had a patient in our clinic that was diagnosed with a testicular cancer that was a size about 10 centimeter size, very apparent, but no one had seen him unclothed for about 10 years. Okay, so one of the things I emphasize that individuals that are low communicators, general physical exam annually. And it doesn't have to be with somebody that is an autism specialist. It just needs to be somebody that has a stethoscope and a blood pressure monitor and knows the rules for preventive care in adults. So I don't know if anybody's read Neurotribes. Have you read the book? It's a pretty good book. So Hans Asperger, this is a quote from the first known public lecture on autism. The audience were Nazis. So kind of interesting. It's an interesting book. It goes into a lot of the history, but there's a lot of disagreement or controversy over how Hans Asperger should be viewed. But we should give him credit for this very forward-thinking sentence that he said here. You know, not everything that steps out of line and thus abnormal, but must necessarily be inferior. So thinking about inclusion, how do we do this? You know, how do we improve our job where we're failing as a community in supporting young adults on the autism spectrum? There's a lot of opportunity. There's a lot of places that I think we can have an impact in these gears of life that can impact quality of life. Okay, and you know, some of the stuff we have access to as physicians and psychologists and such, but a lot of these things, you know, we don't have great ability to have an influence on. And it really is our community and our community leaders that need to step up and have this influence. We've seen some great progress in some areas, I think, that influence this. So one of I'd say the greatest successes that we've had over the years has been the establishment of the recognition that applied behavioral analysis or behavioral intervention, early intervention, targeted therapies that have been proven to work through behavioral methods have been recognized as medically necessary in this field. We can always, we have Arzu in the room, who's been really was the key player in seeing this legislation move forward. But we still have room to go. What we have now is as providers, I can write a prescription now, so now a child can go sit on a wait list and not get services. So we've got a lot of, again, we're partway there, but we've got a long way to go still. On the employment side, we've seen some great success nationally, internationally, locally, And again, a long way to go. This is a notation from a study that was published out of a program that was run through Virginia Commonwealth University, VCU, showing that supported employment, where you really identify the interest of the individual and you support them in their behaviors and you support their employer to understand their behaviors, you can have successful employment. So you can reverse the numbers. The numbers that we traditionally see in employment, the control group, 1 out of 16, so again, those low employment numbers. Instead, with a well-designed program, employment jumped to 21 out of 24. So again, this is something that is doable. We just need to design these programs, and the programs are out there. We're just not necessarily applying them. And focusing on employment, I think, is a great area to focus. We all on both sides of the aisle, like the concept of having taxpayers instead of tax burdens. So employment is good. And the nice thing for the individual is that there's evidence that employment becomes the treatment. And it makes sense that for continued lifelong learning after school ends, where do we learn? There's a large component of our learning that's occurring at the workplace. And if these young adults don't have access to those jobs, we're preventing that access to continued learning. I think the highlighting on this, I think, is, again, I think this goes well beyond the work with the individual. This requires working with the coworker, working with the manager and the supervisor. So it's not what we traditionally do in supported employment. If an individual has a back injury and has to be retrained for another job, the focus you can have successful outcomes focusing on the individual, making accommodations and getting them in the workplace. This requires a different approach, but can be done. The methods that we're using to teach, there's a big debate upon, in the education system about what's the best way to maximally educate individuals into adulthood, and certainly opportunities for that. So we see, this is kind of a list of some of the things that we're seeing locally. We are seeing the School to Work program that's expanded beyond King County has been very successful, has significantly improved employment outcomes for individuals transitioning out of school programs. Project Search is an example of a very tailored, specific program that has had good outcomes. Again, this is that Wayman study that I cited earlier. We're seeing programs emerge at different colleges, such as SPU here. We're seeing them at some of the community colleges. So I think, again, we're seeing progress in this area of these kind of tailored programs that meet the needs of our young adults with the autism spectrum. This is a slide that I may have to adjust. Just recently, there's news on this. We're not sure exactly how this money is going to be spent. So this is exciting funding coming down from federal to our Division of Vocational Rehabilitation, or DVR, that is targeting pre-vocation years, so age 15 to 18. And we've been saying this for a long time, that to have successful outcomes at employment, we need to be doing a better job during the high school years of giving opportunities for individuals to be exposed to the workplace, to help form their ideas of what they might want to do, and gives us an opportunity to be thinking about what they might be successful at doing. A lot, or I'd say even most of individuals on the autism spectrum, when they're in their teen years, they're not good at seeing the future and planning for the future, right? They're really good at seeing the moment from their point of view. They're very good at that. So we have to do extra work there in seeing that for them, and helping them see that future, okay? One of the very successful employment specialists, I was talking to him in his methods, and he said he would always go, so he was a job trainer. He said he'd always go into the individual's home and into their bedroom to see what they like. And he said so many times he would look around and he would be able to figure out, oh, okay, I think I know what you might be good at. And that he feels that really significantly increased his success rate of finding good jobs for individuals. All right. On the area of just housing, which is a big concern, as we saw our parents from our Next Steps classes often saying, where are we going to live for adults? We are seeing progress in this area on the state level for funding and community engagement. And again, this is just, we're excited to see new funding coming in from the Developmental Disabilities Administration for individuals that are more severely impacted and that are going to need that lifelong support. There's, again, a lot of room for improvement in this area. So, for instance, with the Individual and Family Services waiver, which is a funding source that is now available as of last summer, there's a bunch of items. It's like a menu of services that you get to choose from, and the funds are semi-discretionary. However, again, when you get to certain items, they don't have anybody to offer those services yet. So again, we're seeing progress, but we're not there. And I'm going to highlight a couple of our programs in the community. I'll focus on the one that I'm familiar with most, which is the Alyssa Burnett Adult Life Center, which is out in Bothell. This is a program that we set up through Seattle Children's based on a gift that was given to us. It was basically a building kind of handed to us from a family, Charlie and Barbara Burnett, whose daughter Alyssa is in her late 20s and really needs ongoing continued support and needs that lifelong learning opportunity. We've set up this program really as a school. So we run classes on the UW quarter system, but the classes are focused on life skills, social skills, recreation, and vocation. So classes in music and art and cooking and job interviewing, a variety of different opportunities. We have about 80 participants or students at the program currently. We have about 50 volunteer student interns. I wouldn't say they're really volunteer because they are actually getting, a lot of them are now getting class credit that are coming over from the UW Bothell campus that has really provided a great group of individuals that are peers to create friendships and for our young adults to learn that are the participants. And also we get a little labor out of them, which is good. And also we're helping expose. Again, I think if you look at the individuals that work at the Autism Center, if you ask most of them where they got their idea to go into the field, a lot of them, they had a sibling, they had a relative, or they worked at a camp one summer and fell in love with the work. And so a lot of what we have to do is just exposure, to the general population. Joe Smith that owns the tow truck company, he may want to help, but he's afraid, and he doesn't have the opportunity for interaction. And so we have to create those opportunities. We have to get out in the community. We have to create these relationships with businesses and with other organizations in the community if we're going to improve what we can, which is providing that support. And then I think we can see that trajectory for most individuals continue upward, like we see when an individual does have those opportunities. So I'm going to end there. Just to highlight Forrest Sargent. Anybody know Forrest? So Forrest is in his early 20s now. Forrest, I like his story. He is essentially nonverbal. He had run into severe disruptive behavior problems in his late teens, led to multiple inpatient hospitalizations at our psychiatric unit at Children's Hospital. His parents were convinced that he could communicate, but could never find access for him on how to communicate. They eventually developed a system where they would use a stencil board with letters, and he would have a pencil, and he had very significant motor dysfunction, so he couldn't type, he couldn't use an iPad or things like that, but he was able to poke through the letters and spell words. And first time he demonstrated this to me, he's asked, am I okay? And then he said, I want to be a photographer. With that discovery and that improvement in his communication, his behaviors have significantly improved. He's still very autistic, and it certainly didn't make his autism go away. But it sure made him happier. It sure made his parents happier, and it's improved the quality of his life. I think the point of that question is I think that we sometimes set the bar too low, okay, and we have to learn how to open up our minds to potential for this population, and I think we're going to see some really fun things. And I think that for me, my personal experience, I'd say my life has been enriched so much by having so many people that are different than me in my life. My tendency is to have a small world, but I think my life is richer because I have this large world and so many people that have differences, and I think we create such better fabric in our society. And if you talk to businesses that have welcomed an individual into their business as an employer, they'll talk about the benefits that the coworkers have and that the business gains as a whole. For these same reasons, it creates more of a family and more of an environment, and there's greater fabric. So with that, I'll end. I don't know if I have any time for questions, maybe a few minutes. Yes?
Here you showed that the trajectory continued upward in one of your slides, depending on factors that has to do with the brain development, such as cognitive ability, social behavior, etc. I'm just curious if you or your colleagues have done any retrospective studies looking at the brain development, for example, using PET scan or MRI.
So the question of looking more at using tools such as MRI imaging or other measures, kind of objective measures to try to better predict outcome and to better understand those trajectories. It's a great question. I'm going to twist it a little bit from the standpoint of there's a huge push in this field for identifying quote-unquote objective biomarkers of all these symptoms and features that we see in autism. It's been a field that has lacked blood tests and imaging and things like that other fields have that help define both the condition and help better identify treatments. A great example in my career, I also work in the field of multiple sclerosis. Multiple sclerosis significantly advanced treatment options when MRI scanning was started to become popular because the MRI scan showed the abnormality in MS. So what happened then is treatment trials could look at response on the MRI scan that would show up early and could predict clinical response 2 years later. In autism, to recognize a response to treatment, it takes often years, and there's so many confounding factors. So if you don't have those biomarkers, it really limits our ability to do treatment trials. So there's a big interest and a lot of people looking into identifying both electrophysiologic markers using tools such as evoked potentials and EEG genetic markers and imaging markers, I think in those three areas. And research both here locally at University of Washington and throughout the world. So, yes?
How can we learn more about first steps?
So first steps and next steps. Yes, so these are two classes actually that we run actually. So first steps is a class that we run at Seattle Children's for families when they initially get diagnosed. And we encourage just about every family that has a child that's diagnosed with autism to attend these classes. It's a series of 3 classes that are run by our providers, usually in small groups, 5 to 6 sets of parents, trying to hit on all the topics that are going to be salient and relevant. Next Steps focuses on this transition age. We currently run those classes only for families that are already registered at Seattle Children's Autism Center or at UW Adult Autism Clinic, although we have been talking about trying to explore ways to get these programs out into schools, actually. And I think we talked about this at another. And nothing new yet on that. We might be doing a pilot this fall with one of the schools, but yeah, too early for me to.
Well, should parents lobby for that?
Well, I think that a way to do that now. So there are other sources for these, but I think our classes are really specific. I think they're well designed. One way to do would be to get into the Autism Center and then, for a transition assessment. And so we actually have that for youth. And so one of our nurse practitioners or one of our MDs or psychologists, can do an initial visit and then refer you to those classes. So, but I like the idea of lobbying, and we'll talk more about it later. I'm going to get to a couple other questions. Okay, yes.
I have a question. So when you were talking about social engagement and mixing that with exposure, have you found that when adults with autism are either living at home with their families versus living in a group home that has maybe planned events, or maybe living in a facility where they're kind of on their own agenda and decide what they want to do, have you found more success in one of those versus, because I understand the burnout. I'm already there and I have a 6-year-old. I'm burnt out. But planning for his future, trying to look at different options, I'm trying to figure out, I can make him go out by saying, we'll ride an elevator. First grocery shopping, then elevator. And he's like, yeah, let's go. But if he was up to his own, he's his own best friend. He'd rather stay home.
Right.
So I could see where the engagement numbers would go down if he was on his own to make his own decisions.
Right, and so on the one hand, you see that case manager role, right? The importance of being involved, but there's this other aspect of least restricted environment, right? That we hear when we talk about the schools that applies also in the community, both in living and in the job, and that the best outcomes are the least restricted outcomes. We have very little data on populations as a whole with the specific question. I will cite one study that was done a number of years ago that interviewed moms of young adults on the autism spectrum, divided between those that were, their young adult was living outside of the home versus those still living in the home. The moms of those living outside the home rated the health care and quality of life higher, but they rated their guilt higher. Yeah.
You mentioned gender differences in employment. Are there other notable differences in other outcomes?
So the question about gender differences in employment is an area that has not been well researched. So there's very little data on that. That one slide highlighting this kind of loss of employment over time has been observed in both males and in females. There are some, and this concept of autism in females is kind of a continuing, we're learning a lot about that. There's finally some research occurring that. I think the things that we can say about what we know with that in general that can relate to the workplace as well is there's tends to be higher social interest in females. So that's good, but the social world is more complex. Males are a little simpler, so, in a lot of ways.
Does it extend to other areas
Yeah, so I think it does. I think there's a lot of times the female will, on the surface, look more typical from the standpoint. They're more verbal, they have more social interest, okay? But then what happens, and so the expectation is higher. Okay, so that's my kind of take on that. So, yeah. We're going to wrap it up. So thank you very much. We got even better time with the panel, so it's going to be good. Thank you.